Hi, I'm Tony Bach, and I'm a medical oncologist at the other Washington in Seattle. And I'm going to be talking about communication tools, especially for prognosis. It made sense as we were designing the session in the flow of this, although I appreciate that my talk in the program is listed more as communication about the end of life. So I'm going to talk about addressing prognosis, and we will have plenty of time for questions at the end. So if you have a question about something that I haven't covered, please feel free to bring it up. You know, when the future is uncertain, what your doctor says means a lot. And you know, there's more even empirical data to support this now, you know, the work of Jenny Mack and Therapeutic Alliance. But the big point I want to make here is that facing these moments, and this is the work of Angelo Mirandino, actually, this is a fantastic photograph. These are not things that you were born with. These are things you learn. It's very clear from the literature and the research that communication skills are a modifiable attribute of clinicians. And so what I want to do today is talk a little bit about some of the things I think you can modify, both in being more observant and observant of different things with the patients you're with, and different in the way that you come across, and in fact the way subsequently that your patients respond to you. So I'm going to talk about factors that shape patients' understanding, a little bit really default communications that oncologists do, including me, demonstrate on communication tools that improve understanding and trust, and that's actually the bulk of my presentation. You know, just to go back to catch Don's anecdote about the power of words, you know, these are quotes from his blog. You know, he, in the most well-intentioned way, went in and said, you know, this failure of first-line treatment, and the patient responded in a completely unexpected way. You make it sound like it was my fault. I'm sorry I failed, and I'm sorry I disappointed you. I mean, this is one of those dynamics that actually I didn't believe until I had heard a couple of patients say it in study interviews about the sensitivity that patients have towards how they perform for us. And I do think that these kinds of moments of stepping back in our own work are really important, because what it creates for you is this kind of ability to take the metacognitive step backwards and sort of see what's happening. This is Suleika Jawad, who is the woman with leukemia who's blogging for the New York Times, and this fantastic picture from the New York Times that shows, interestingly, her clinician over at the computer. But what shapes these moments? Because, you know, you walk into these rooms, people are waiting for you, and here are the things I've culled from the literature about what matters here in terms of what patients are thinking when they talk to you. You know, they have assumptions which are both from what they've learned, either through their culture, through the internet. They have their level of sort of medical understanding, the biomedical level of understanding, and then there's this medical literacy issue that comes up, which is very wrapped up in, you know, how patients respond to statistics and how they see statistical information. You know, the fact that this statistical information is so difficult to take in and interpret for yourself, I think, is evidenced by the popularity of Stephen Jay Gould's essay called "The Median is Not the Message," which was about his own experience as a person with cancer dealing with median survival. Anyway, on the other side, the clinician side of the equation, there are communication skills, there's self-awareness, there's empathy, there's oncologic expertise. Now, you may feel like these are things that just come in the package of you, but in fact, there's quite a bit of evidence that every one of these things is a function of training and experience, and not just something that you were born with. You know, what happens currently? Well, you know, I'd say that that one of the big issues that all of us face is that we have habitual ways of explaining things. You know, some of the researchers politely call these routines. Some of them call them monologues. In some of the studies that we've done, audio taping oncologists with patients, I mean, there is this clear phenomenon that we called in one of our papers broadcasting, which is where you kind of hear this clinician talking back and forth with the patient. They're doing this history thing, and all of a sudden he'll go into his or her sort of thing about the disease, about the treatments, and then the transcript is like, you know, 2 pages of single-space typing. And I think these oncologists actually mean well. I think they are trying to give a really clear, honest, you know, complete explanation. And so they're doing, in fact, what they really think will be the most helpful thing. And yet what happens is, because they miss some other cues while they're doing this, patients end kind of a little overwhelmed, a little information overload, a little kind of wrapped up in their own experience, and they don't catch it all. You know, because what happens is that we doctors, at least speaking for myself, we tend to focus on the technical, right? If you look at the program here, it's like 95%, you know, pretty technical stuff. And that detail orientation and the level of specificity you need to have when you're making a really good oncologic decision is more complicated than ever now, right? The complexity is, you know, rapidly escalating, and being detail-oriented is clearly a strength for a clinical oncologist. But it's really easy to narrow your attention and focus just on those little biomedical things, and then you kind of miss the other stuff. Like I'm always flipping through, I do GI oncology, so I'm looking madly through the chart for people's, you know, KRAS mutation status, and then I just sort of, you know, just kind of blinds me to everything else. Because what happens, and what we see in studies, is that the frequency of acknowledging emotion is low. You know, what's the end product of this? Well, you probably saw this study by Jane Weeks' group at Dana-Farber, studying you know, almost 1,200 patients with metastatic lung cancer or colon cancer. They thoughtfully studied them 4 months after starting treatment for their metastatic disease, which I thought made a lot of sense, because that is a time point in which you'd think, well, you know, they've gotten their diagnosis, the initial shock is kind of over, they're in a treatment routine, right? They should be pretty well adjusted. I mean, you would think a good time to check patient understanding, and yet it's pretty terrible. I mean, the patients said, you know, 69% of the patients with stage 4 lung cancer said that there was some chance of being cured. 81% of the patients with colon cancer said there was some chance of being cured. And, you know, cultural mismatches put patients clearly at higher risk for misunderstanding, right? All these major, you know, diversity issues, you know, it's kind of a disaster, really. The flip side of this is talking about prognosis is really hard. I mean, I think there's this technical difficulty that we face in needing to translate these very complex statistics into something understandable by an untrained person. I mean, there's this issue about what does median survival mean, and these decision aids, which I think, as Mary talked about, I mean, I think they're fantastic, and yet there's just not a lot of decision aids for most of the things I face in day-to-day practice, right? And some of the things that you think would work, actually, it turns out, are not as helpful as you would hope. So one of the issues that we have studied is this issue of, you know, was the doctor really truthful? Did they really give him the information, right? And the bottom line is, giving the information is not the whole story. Right? So this was a study that we did at the Hutch and at the Dana-Farber for oncologists who were seeing patients with hematologic malignancies. 88% of these patients wanted quantitative information. That's why they were going to these, you know, specialized centers. 69% of the visits, we audio recorded them, and they included the physician saying what the number for survival was, or the number for treatment response. But right after the visit, when we asked patients to fill out a survey about what do you think your chance of being cured is, what do you think your chance of, you know, of having a treatment response is, you know, most of the patients indicated something about their survival that was more than 2 categories different than what the oncologist said, meaning more than 20%. And that whether or not the physician had actually said the number in the audio recording was not correlated with doctor-patient concordance, right? Ooh. Like, what's that all about? Well, what it's about is people are blown away by the number and they just don't hear anything else. I mean, it's a little like what Mary was talking about, but you know, one of the patients in the study said 2 weeks later, you know, he said 30% and all I wrote for the rest of the visit all over my paper was 30% and I just didn't get the rest of it and I don't even know what happened to me. It turns out those moments are what often get missed and what I think accounts for part of the problem here. That's my hypothesis. And what leads me to this is part of this data is that there's not a lot of acknowledgement explicitly of those kinds of emotional moments in outpatient oncology visits. Right? So this is the largest observational study of this kind of communication that's ever been done. It was done at the cancer centers at Duke University and the University of Pittsburgh by a couple of friends of mine. They recorded almost 400 outpatient oncology visits with patients with advanced cancer. They looked in the audio tapes for instances where the patient both showed some kind of emotion and whether the doctor responded to it. And by and when I say response, I mean something where the doctor did some kind of explicit acknowledgement of it. So, for example, the example that Don showed, his example from Sex and the City, the woman goes, "How can this happen to me?" Right? And he goes, and the doctor goes, "Well, it's your genetics, it's your this, or your that." And in fact, at the end, she's like, "Okay, I'm out of here." That is actually one of those examples where the doctor actually hasn't notice the implicit kind of emotion cue in that question. So I would contend that that question, how did this happen to me, is a question that's more about the emotion and the shock and surprise of this than actually about, was she really worried about, you know, the genetics and everything. And so, you know, in this study, they looked for these what they called emotional, empathic continuers and empathic terminators. So that, what I just talked about in Sex and the City, that would be a terminator. And 11% of these visits contained an explicit empathic statement. So that's not a lot. That's like 1 out of 10. So it's just not a lot of the time we spend it with people. And yet, you know, there's this other data that responding to emotion actually may improve information retention. So this was done at an outpatient oncology clinic in the Netherlands. They recorded clinician-patient visits. They analyzed them again for information and emotion cues, and they counted how many times that the clinician responded to the emotional cue or the informational cue. So an emotion cue is like this, you know, how can this happen to me? The information cue is, I need to know more information about side effects, right? And it turns out that in this study, what patients remembered from the visit was more highly correlated with the clinicians responding to emotion cues than information cues. So this is interesting. It's kind of counterintuitive, right? So you think, well, the more information questions the patient asks and the more information the doctor provides, or the clinician provides, the more they'd remember, right? But in fact, it's just the opposite, right? So what is happening there? I mean, I think, and this is what I see in my practice all the time, an anxious person comes in. Because of their anxiety, they ask lots and lots of questions. You know, the clinician, often me, is doggedly trying to answer all these questions, and I'm thinking, this is going to help this person understand more. I'm giving them lots of information, and yet what's actually happening is they're like, all I hear is the 30%, and I just keep asking these questions, and it's this kind of vicious cycle of anxiety that we don't see fast enough to stop and slow down. Because if you can do that slowing down, it actually does create more trust. And this is data from the same group at Duke and the University of Pittsburgh. They did a randomized trial of teaching oncologists to notice emotion cues and respond to them empathically. And the response empathically is verbal. What they're teaching people is verbal empathic responses. And what that does is kind of create a moment in the conversation where things slow down for a minute. And that's what enables, I think, people to process a little bit of what's happening. So in the results, the patients of the trained oncologists, and this was a randomized study that randomized the oncologists, not the patients, gave higher trust scores to the oncologists than the patients of untrained oncologists. Now, it's quite interesting. Now, of course, you know, this isn't a study where we have yet more downstream information on outcomes, but it's certainly interesting and promising. Because I'd say that this is the most common issue that I see as a pitfall when I'm dealing with fellows. Now, it turns out there are the occasional patient where responding to their emotions and talking explicitly about them probably isn't a good idea. And the example I would give you is somebody with really chaotic emotions who's really out of control. For example, I have a patient with an addiction issue. She comes in all over the place. She's kind of screaming. Someone talks to her about her emotions, and it actually amplifies her emotions, like they zoom way up. And for those people, and I think those are a small subset, you may need to actually help them contain their emotions rather than explore them, right? So I do think there are exceptions to this emotional, this rule of acknowledge emotion first, slow it down for a minute, then explain. Because there are patients who won't be able to slow down. But for the majority of people, I would say that really helps. So what kinds of practical tools can I give you here? And so these are 4 that I wanted to highlight that are useful in talking about prognosis. 1 is making an offer. 2 is acknowledging emotion. 3 is giving information in bite-sized chunks. And 4 is asking for teach-back. These are basically tools. I mean them in the way that a master craftsman has a whole selection of different things and can pick out exactly the right thing he needs. That's what I think we all need, is a bigger repertoire of things. Because rather than relying on the routine, when the routine doesn't work, you have to both notice that, stop, pick out the different tool, right? So offer to discuss the future. A couple of examples. How much have you been worrying about the future? A second one, sometimes people are hesitant to ask about what to expect or statistics or prognosis. Third, what information about the future could help you be more prepared? So notice that I actually didn't use the term prognosis in these questions because I think prognosis is pretty technical for a lot of patients. But I think the studies make it very clear that people really want to talk about the future. They want to be prepared. And so these are not yes-no questions. Notice the second question, or the second statement, is kind of a normalizing statement that normalizes that it's an awkward moment for many patients and for the doctor. And then the third statement is really about building in the reason it's worth discussing something awkward or painful or scary, right? If you're going to ask someone to talk about something really awkward, there's got to be something in it for them. And what's in it for them is it helps people be more prepared. Second, acknowledge emotion. So if you notice a cue, somebody says, I'm scared, or just as commonly, and this wasn't in the study I showed you, looks down, looks away, isn't paying attention, asks you something about something that you weren't even talking about. What that means is that they're kind of, discombobulated. And so that's time for you to stop and say, I can see you're concerned about this. Tell me more about the thoughts or feelings that are going through you right now. Or kind of acknowledgement, this is hard to hear. Now, I am not expecting that a simple acknowledgement like this is going to resolve the emotion. That's really not the point. I'm not asking you to be a therapist, and most of them are not coming to you to be a therapist. There are other people for that. They want you to help them with their cancer care, right? But by doing this, what you do is slow everything down for a few moments, give that wave of emotion time to sort of pass through, and that puts you in a different place when you restart the conversation and go back to the place where you were right before. 3, give information in bite-sized chunks. Mary talked a bit about this, but I did want to give you a couple of things here. This is one way of explaining median survival. If I had 100 patients, this is my verbal description of her diagram, actually. If I had 100 people with the same type of cancer and same stage as you, and I followed them over time, by 2 years, half of the 100 would have died of the cancer and half are still alive. It turns out there are studies that validate the use of 100% because people get that, so that's actually what I use now in preference to 10%. The other tool I've listed here is about best case and worst case survival, and that comes from Drs. Kaili and Tattersall in Sydney, where they've done a lot of really great communication work. One way to talk about this is the best case scenario we see is around 90th percentile, meaning it's something you really do see. It's not something you were just heard about, right? The worst case scenario we see is around, 4 months, right? Again, something I've seen, not something that I think is a horror story. And I think actually they have done some preliminary work talking about, with breast cancer patients, about using all 3 of these things, both median survival, best case scenario, and worst case scenario. And it's a way of bracketing the survival thing. But obviously it's one of those things that requires a little bit of an investment, but I think often pays off because patients have the sense that you're not just giving them like the death sentence of a certain period of time, which is a frequent misconception. Fourth, ask for teach back. There's been a lot of stuff about teach back and quality, so I'm kind of using that terminology even though it's not really exactly the same thing. But the point is, when you ask people to tell you what they've taken away, it is totally illuminating for you about how much is getting across. And so one way to do this was to make it not like a quiz, because you don't want them, they've already been through enough. The last thing they need is like a quiz at the end of their visit, right? Is tell me what you're going to tell your best friend when you get home. Tell me what you're going to tell your sister. Tell me what you're going to tell your husband. It'll help me know if I've been clear, right? So you're both asking them, rehearse, giving an opportunity to rehearse, and then telling them it's actually for you. Right. Then the second thing is what are you taking away from this part of the discussion? In our study of oncologists that I talked about with the hematologic malignancies, we kind of looked through all of the visits for this, and actually there wasn't a single instance where a doctor stopped in the middle of their discussion and said, what are you taking away from this part? And these were, 60 to 90-minute visits with a median of 9 recommendations. So they're pretty complicated. And I think there are many of us in just regular practice or other kinds of practices who have visits that are that complicated. And the issue I would say about this is, because I appreciate this takes time, and yet, you want the time that you spend with patients to pay off. Having you spend a whole lot of time and give a whole lot of recommendations, if they don't remember anything when they leave, or if they only remember one of them, you know what, I actually would make a case that you could invest your face time in a more critical way, in a way that has more value for them and for you. Because, answering a million phone calls after they're gone is, nobody's idea of a great afternoon. So here are the key skills. Offer to discuss the future, acknowledge emotion, give information in bite-sized chunks. Ask for a teach back. Okay, one last thing, because I just can't resist. Okay, positive reinforcement is incredibly powerful. I don't mean meaningless positive feeling, like, oh, you're doing so great, all that, stuff. But, we do live in a culture of shame and punishment. You're right, this is American medicine. And so for you to express appreciation for the work that it is to be a patient, because here, you know what, in the United States, I don't know about you guys internationally, but in the United States, it's a full-time job, right? It is incredibly powerful, and one of the things that you can do to really help build rapport while you're there. This is Leroy Sievers, the blogger for National Public Radio, who died a couple of years ago of cancer. And the reason I like this is because, there's a lot of canned stock photography about doctors and patients, but this is a real conversation. You can tell just from their faces. Right? And it's very interesting to me the doctor has seated himself a little lower. We were talking about nonverbals. A couple of other things. Of course, what I've talked about here is just the beginning of a learning curve, or way stations for those of us who are further along in practice. You can check out our book. We just released an iPhone app on the iTunes Store, which you can check out at Vital Talk, which is actually 2 words on the iTunes Store. And that's it. I think we have some time for questions.